Today, we're going to be talking about updates in breast density. We're going to be talking about where we have been, where we are now, and where we're going in the future. So the goals and objectives for today's talk are to review the definition and implication of dense breast tissue on mammography. We will discuss breast density notification laws and how they impact our community here in Vermont, as well as across the country. We'll describe what is a screening breast ultrasound, the various types of screening breast ultrasound that we can use, and their role in detecting breast cancer. Specifically, we'll aim to talk about breast density. What is it and why is it important? We'll talk about breast density legislation, which we've seen sweep throughout the country. And we're also going to talk about screening breast ultrasound, which you'll see me abbreviate throughout the talk as SBUS, in case you wonder what that means. So I wanted to just start and talk about what is breast density. And breast density refers to the bright white areas that we see on a mammogram. So these images you can see on the screen are standard mammographic views that we get every time we have a screening mammogram. And the areas that look white or bright on these images, which you can see outlined in red, are the fibroglandular tissue. So these are the regions of the breast that actually can create milk, and these are also the regions of the breast that can actually create a breast cancer. So the other areas that we see on the image are darker in color, or radiolucent, as we radiologists say, and these are areas of fat on the mammogram. And so the areas of bright white are the fibroglandular tissue. The more areas of white that we see on the image, the denser the breast. The more areas of dark or fat, the less dense the breast is. So what happens when we take a very magnified view of the breast? When we look at fatty breasts and dense breasts under a microscope and actually look at the cells that make up that tissue and make it look different. Well, what we see is here on the left, this is what we call a photomicrograph of a fatty breast. And what you're seeing here are these little round white cells, and these are tiny little cells of fat cells, and you can see that they're basically translucent. We can see through them very easily, and you can sort of imagine how an X-ray could really easily pass right through these cells, and we could see really, really well on the mammogram right through them. And contrast that with the image that you see over on the other side of the screen, which is a photomicrograph or a very magnified view of dense breast. And what you see, which is obviously very different from the first image, are that you see these denser, more pink, more solid areas. And this is the dense breast tissue, which you can imagine an X-ray trying to get through this very dense tissue. It would be, the X-ray wouldn't be able to get through as well as it could with the radiolucent fatty breast. And so you can imagine the X-ray sort of getting deflected and not being able to really pass through and image that tissue well. So this is a microscopic level of what we see on the mammogram as dense breast tissue and fatty breast tissue. So on the mammogram, there are 4 basic categories of density, and they range all the way from the picture here, which is marked by A, which is considered a fatty breast. These are the most radiolucent, the most dark. They have the highest fat composition and very little fibroglandular tissue. There's very little white on this image. And the density categories range all the way up to the image that you see all the way on the right, which is labeled with the letter D. And this is considered an extremely dense breast. You can see how much white, bright areas of fibroglandular tissue you see in that breast. That is absolutely the most dense breast that we encounter. And then there's these 2 middle categories, which are marked by the letter B, considered scattered fibroglandular density. That's what that category is called. The third category, which is C here, is what we call heterogeneously dense. And so those are the 2 middle categories. If on your mammogram, you're classified as having dense breast tissue, then by definition, you are in the top 2 categories. You either have heterogeneously dense breasts or extremely dense breasts. If you're considered not to have dense breast tissue, then you're in the bottom 2 categories. Either you have a fatty breast or what we considered scattered fibroglandular density. So we know that having dense breast tissue is unbelievably common. This study was put out in 2013, which shows data from the Breast Cancer Surveillance Consortium, suggesting that in the screening population of women who have dense breast tissue, it's about 46.9% of those that are screened. So almost 50% of American women out there who are getting screening mammograms will have dense breast tissue. This is a very, very pervasive issue that 1 out of every 2 women has to face, having dense breast tissue. So it's very, very common. Since the 1970s, there's been a proposed connection between breast density and breast cancer risk. And you might ask, how much is that connection? What's the real risk there? Well, we know that women who have dense breasts have a lifetime risk of breast cancer, which is about 4 to 6 times the risk of women who don't have dense breast tissue. So that's a fairly significant increase. We also know that false negative mammograms, so mammograms that are read as negative or benign, and the woman actually has a breast cancer there, but it's not detected on the mammogram, that's 10 times more likely to occur in women who have dense breast tissue, which can cause an elevated rate of advanced stage cancer. So it allows the cancer to grow a little bit larger before it's actually detected. And that's more likely to occur in women with dense breast tissue as opposed to fatty breasts. We also know that dense breast tissue is associated with larger and more aggressive tumors, as well as lymph node positive disease. So sometimes the breast cancer can get so large that it actually moves into the lymph nodes in the armpit, which can also increase the use of a more aggressive surgical management, such as a mastectomy. Why? Why does this happen? So what is the connection? We've been wondering for years and years, why? Why do women who have dense breasts, why do they encounter such elevated risks of breast cancers? Why are their mammograms hard to read? And why do they have these aggressive forms of breast cancer? Well, the answer is a 2-pronged answer, which we've come to discover. The first prong of that answer is what we call the masking effect. And that's what's created by the dense breasts mammographically. And I created this graphic to sort of show what we as radiologists, as breast imagers, encounter when we're reading a mammogram on a woman who does have dense breast tissue. And so the image here, you can see on the left, this bright white circle is meant to depict a dense breast. The image on the other side of the screen, the dark black image, is meant to depict a fatty breast. And you can see what happens when a mass grows in each of those breasts. Obviously, it's a lot easier to detect the mass that's growing in the non-dense breast, as opposed to the dense breast, which is completely obscured by all of that bright white fibroglandular tissue that you see there. And so because of the masking effect, we know that those women who have an increased density on their mammogram, who have dense breasts, have a much lower sensitivity mammographically. It's a lot harder to pick up those breast cancers in these women. And so that's why, if you look at the mammogram report that we create, we use the phrases, the breasts are heterogeneously dense, which may obscure small masses. It may obscure a very small mass that we can see that may be present in the breast, which are difficult to see. Or we may use the terms, the breasts are extremely dense, which lowers the sensitivity of mammography. So you may see those words in your mammogram report, and that's why we put that in there, to sort of express to you that you are in that dense breast category, and because of that, it may be harder to find a breast cancer. The sensitivity of your mammogram may be a little bit lower compared to a woman who does not have dense breasts. So you might ask, well, how much lower? You know, is it really significant, that decrease? Well, it is actually pretty significant. The sensitivity of mammography in women with fatty breasts is about 86 to 89%, pretty high. We know that sensitivity drops about 20 percentage points when we look at women who have extremely dense breasts. And so that's a pretty significant decrease of about 20 percentage points when we're talking about sensitivity, how easy it is to pick up a breast cancer on the mammogram. And because sensitivity is a little bit lower, about 61 to 62% in women with dense breasts, they can yield a higher number of what we call interval breast cancers. And those are cancers that will manifest within 1 year of a normal mammogram. There's a higher rate of that happening in a woman with dense breast tissue. So remember I talked about there being a two-pronged answer, and the first prong of that answer being the masking that we just spoke about. Well, the second prong of that answer is that we've also found that breast density is actually an independent risk factor for breast cancer. And the reason for that is we talked a little bit about how breast cancer can arise in the fibroglandular tissue of the breast, but specifically breast cancers commonly arise from what we call epithelial cells. And those are cells that exist in the breast, and sometimes they can be there can be a few epithelial cells in the breast, and sometimes there can be many epithelial cells in the breast. And the number of epithelial cells is related to the breast density. So this image here at the bottom of the screen, at the left side, you'll see a very fatty breast, and the fat cells are symbolized by the yellow and brown circles there. Those are meant to be fat cells. And the pink little dots that you're seeing, those are the epithelial cells. And you'll see in the fatty breast all the way on the left side of the screen, there's really not a lot of epithelial cells. But you'll see as the density increases in those four categories, which we previously discussed, and you get all the way to the right side of that graphic, we can see in an extremely dense breast, there's a lot of epithelial cells. And because there's more of these cells, there's a greater chance of breast cancer developing. And so that's thought to be the reason why breast density is an independent risk factor for breast cancer. We've also found that this association of breast cancer with increased breast density does not decrease over time. So even if the breast does become less dense over time as menopause happens or various reasons, that association with an increased risk of breast cancer does not decrease, even up to about 10 years after screening. So why can breast density change? What kinds of things can cause it to change? This has been a major cause of confusion for patients. We get phone calls all the time and have many discussions with patients about, why that can happen, what sorts of things can make that change occur. And there's a whole list of things. The first of which is really based on in the interpretation. So it can definitely happen where a radiologist might look at your mammogram and give you one density, and then a year later, your mammogram is read by a different radiologist, and that radiologist may differ a little bit in the density that they apply to your mammogram. And so certainly there can definitely be a lot of variation with regards to the density that's assigned. We also know that physiologic changes can cause changes in breast density. So things like body mass index, which obviously can change from year to year. Age, as a patient ages, their breasts tend to involute or become more fatty with less tissue. We also know that hormonally driven medications such as tamoxifen or extrinsic hormones or hormone replacement therapy, that can certainly change the density that we see in the breasts. Normal weight changes or changes in dietary intake can definitely elicit changes, and even just basic breast positioning. So every year when you come in for your mammogram, we try to simulate the same position that we've had from year to year to try to minimize this, but inevitably there's going to be slight changes in the way the breast is positioned for that study. And so things can look a little bit different. So there can be some subtle changes. And so we spoke a little bit about how breast density is somewhat of a subjective measurement, meaning that it can change from radiologist to radiologist. We know that the agreement of a radiologist in terms of breast density really only occurs about a little less than 50% of the time. We usually agree as radiologists on either end of the spectrum. So when we're talking about a really fatty breast, most radiologists would agree with that. A really dense breast, again, most radiologists would agree with that. Those middle two categories, they tend to fluctuate a little bit. So it's not uncommon for somebody to be considered in the second category 1 year, and then the following year they come back and all of a sudden they're in the third category, and they're really alarmed to see that change. And there is quite a bit of subjectivity there. There's even subjectivity in terms of a single radiologist. So we've actually found that there's not a lot of reliability in terms of the same radiologist reading a mammogram one year, the same radiologist reading that mammogram next year. There may not be a significant, they may not agree with their own measurements. It's very, very subjective. And because of that, that normal human variability that we tend to see, various companies have actually come out with automated quantitative tissue density software. So these are computer programs that actually look at the mammogram themselves and sort of assign a density based on their algorithm, their computer algorithm. And so we actually do use that now in our breast center to sort of iron out some of that subjectivity that tends to occur in those second and third categories. So here are some examples I found in the literature, which I thought would be helpful to show. This is a 42-year-old woman who presented for screening, and the very first image she had is here on the left, and she was assigned to the second category. And then she went on to have gastric bypass surgery and extreme weight loss as a result of that surgery. She came back within a year and had the mammogram that you're seeing on the right side of the screen. And she was actually assigned the extremely dense category. And you can see that certainly there are more bright white areas on her mammogram. She has a lot more fibroglandular tissue now than she did before because of that change in weight. This is another case of a woman who was 46, and so she had not gone through menopause yet. She came in for her screening mammogram. She initially presented here. We can see this image on the left, and she was assigned to the third category, put in the heterogeneously dense category. Well, 8 years later, she came back. She's now postmenopausal, and now she's assigned the first category. And so she doesn't actually have dense breasts anymore. And so that occurred after about 8 years and having gone through menopause. So, just some case examples of how the breast density can certainly change over time. And it can be normal, very normal. Okay, so now I want to change gears a little bit and talk about some of the legislation that has occurred. And the breast density legislation that has occurred throughout the country was actually initially started by this woman here. Her name is Nancy Capella, and she is a breast density activist. And she came into this role pretty naturally. She was diagnosed with breast cancer herself. So she went to go see her doctor because she felt a lump in her breast. Her doctor did an ultrasound and diagnosed her with breast cancer. And obviously she was very upset and alarmed, but not for the reasons that you'd think. She was alarmed and upset because she had had a mammogram 6 weeks before that diagnosis, and her mammogram was read as normal. And so she said, how could that be? How could I be diagnosed with a breast cancer? Meanwhile, I'm coming in every year to have my mammogram. I just had it read and it was normal. How can I have a breast cancer? And so it was explained to her all about breast density and that she indeed did have dense breast tissue. And so probably for that reason, the breast cancer was really difficult to see and was not detected mammographically, but it was detected on ultrasound. And so she was really alarmed because this was news to her. She didn't know anything about her own breast density. She didn't know that she had it. She didn't know that there was another test that she could have used in order to try to find a breast cancer. And so she didn't understand why American women were really unaware about all of these ideas. And so she started to become an activist and sort of get out the word to women everywhere about breast density and about the importance of it. And so because of her work, in 2009, Connecticut was the very first state to pass breast density legislation. And in 2011, there was federal legislation that was first introduced that requires that all patients who have a mammogram know their breast density as a result of their encounter, their mammogram. And they also need to be informed that they may benefit from an additional screening test. So sometimes if you do have dense breast tissue, an ultrasound may be an additional benefit. And so in 2019, a national law was passed which requires the US FDA to develop a national density notification requirement for all breast centers throughout the United States. All radiology facilities are required to inform all women and referring healthcare providers of the breast density, and also tell those women who do have dense breasts that they may need an additional test in addition to the mammogram in order to really be able to thoroughly evaluate for breast cancer. So in March of 2019, the FDA did create an amendment which requires breast density to be reported to patients and their referring healthcare providers. And so you can see, this is a map that I took from a website called densebreastinfo.org. And about 38 states and the District of Columbia have enacted some level of density information for women. So there's some level of legislation in each of these states, which are pink on the map, so that anytime a woman has a mammogram in these states, there is an automatic notification that is created where they are notified their breast density. The level of notification varies from state to state. Sometimes you get a letter saying this is your breast density, and other times you'll get a letter saying this is your breast density and maybe consider getting an ultrasound. That verbiage is going to change based on the state. But you can see that it's very widespread. There's 38 states and the District of Columbia that now have this legislation that really was not in place before Nancy Capella, before 2009. There are also a small fraction of states throughout the country that have employed some sort of legislation regarding insurance coverage. So obviously that is a major player here. There's lots of women out there that might say, you know, great, an ultrasound may help me, but it's expensive. And so we need to know we need help from the insurance companies. They should be able to help us pay for this. And so there are mandated payer states throughout the country. And on that map, on this map here, you can see the mandated payer states are labeled with the black diamond on the state. So while the mandated payer states are not as pervasive as the notification requirements, they're certainly increasing. And so this is certainly an issue that affects many, many women, 40% of American women. So what's going on here in Vermont? How is this affecting us? Well, we are very lucky to live in such a progressive state like Vermont. In 2016, a law was passed which states that every exam that was performed after 2017, we have to tell every patient what their breast density is, what they're classified as, which of those 4 categories. And those women who do have dense breasts will receive the following notice. Now, I won't go through this whole paragraph with you. Obviously, it's quite long. But the paragraph does talk about that you do have dense breast tissue. It's a normal finding. It happens in about 40% of women. It can make your mammogram a little bit difficult to read. It may be difficult to detect a breast cancer, and it could put you at a slightly increased risk of breast cancer. And because of this, you might need to discuss this issue with your doctor and consider if maybe another screening option would be helpful for you in addition to the mammogram. And so this wording only goes out to women who have dense breasts. If you don't have dense breasts, then you will not receive any sort of this notification will not go to you. And what about the mandated payer states? How does that work in Vermont? Do we have that here? Well, we do. So in January of 2019, a separate law was passed which states, it went into effect as of January 1, 2020, which states that all insurance within the state of Vermont must cover a screening mammogram and ultrasound for a patient when the screening mammogram is considered inconclusive or in a patient with dense breast tissue. And these benefits have to cover the full cost of the mammogram and ultrasound. And this applies to only insurance companies within the state of Vermont. And so, you know, we're pretty lucky to be able to have these wonderful legislation. And so how has this sweeping legislation, these sweeping laws that have come into effect in our country, how has this changed our usage of screening? Well, it's increased it quite a bit, as you can probably imagine. The use of screening ultrasound has increased about 5 to 10% in those states that do have density notification laws, which is great. But these sweeping changes, while it's wonderful that the advocacy has swept throughout the country, the legislation has swept throughout the country, and people are becoming a lot more aware, unfortunately, the scientific literature has not caught up. And so the organization known as the USPSTF, which stands for the United States Preventive Services Task Force, has not been able to find sufficient evidence to recommend that supplemental screening breast ultrasound be performed overwhelmingly in women with dense breast tissue. Unfortunately, they really don't have the scientific data yet to support the widespread use. So this is leaving American women very confused. It's very conflicting having these laws sweep throughout the country, everybody up in arms about breast density and what it can mean. However, you know, the USPSTF is really not very clear in terms of their recommendations. So everybody's confused. We're getting tons of phone calls, tons of encounters with patients where they say that they're really unsure what to do. They're puzzled, they're confused. And if that's how you feel with all this information, we completely understand. And you're not alone. Everybody is sort of in the same boat here. So the American College of Radiology and the Society of Breast Imaging has recommended that ultrasound screening be considered in women with dense breasts after a negative mammogram. Obviously, it's not for everybody, but it's something to consider. And so that's sort of been the policy that we've been adopting, where we're talking about it in women who have dense breast tissue. Obviously, we received the notification, but it's not something that we absolutely say has to be done. It's not a requirement, but it's something that's available. So I want to change gears a little bit now and talk about screening breast ultrasound and talk about why the modality, the technology of ultrasound is really appealing in this setting. And the reason that it is most breast centers across the country already have ultrasound. It's relatively inexpensive. It's non-invasive, so there's no IVs, there's no contrast that needs to be given, there's no dye that needs to be given, there's no radiation as a result of it. So it's a really, really appealing technology. However, in the medical world, we look to randomized controlled trials in order to really tell us what appropriate therapies there are out there. And we don't have any yet to support the use of supplemental screening breast ultrasound for cancer detection in women with dense breasts at this point. But what we do have is what's called a large prospective multi-institutional trial. And so this was a trial that was completed in 2008. So it's been a little bit of time since it's happened. It was led by Dr. Berg. And in this trial, what they found was that out of every 1,000 women who had a negative mammogram, but did go on to have a screening breast ultrasound, they found about 3 to 4 mammographically occult breast cancers. And so, that's great news, right? We're finding additional breast cancers that were not found mammographically, but found with ultrasound. But we know anytime we do any test, there's going to be advantages and there's going to be disadvantages. And so obviously the advantage is that we're finding 3 to 4 additional cancers. However, the disadvantage is that with the screening breast ultrasound, we're seeing a high false positive rate. And so what that means is that we're recommending biopsies, we're recommending follow-up ultrasounds on a fair amount of women who don't have breast cancer. We're also seeing something called a low positive predictive rate, which what that means is that of those women who are recommended for biopsy, how many actually have breast cancer? And we typically want this rate to be a lot higher than 6.8%, which is what they found in this trial. This trial actually looked at women who were considered high risk for breast cancer. So these are women who had some sort of family history, some sort of genetic predisposition. They were at a higher risk of getting breast cancer, where we're talking about utilizing screening breast ultrasound in the medium to low risk population. So, we're not really sure how well this study actually applies to the population of women that we plan to use screening breast ultrasound for. So after it was started in 2009 in the state of Connecticut, another study came out and questioned how easy is it for us to implement a program for screening breast ultrasound in a breast center? How can we start doing it across the country and make it at least available for patients should they choose to do it? They found that we could use technologists in order to perform the study, that physicians, radiologists were not necessarily needed to do it, but they did find similar cancer detection rates and positive predictive values to what was seen in that initial study in 2008. But when we looked at lower risk populations, the cancer detection rates were not as high as that 3 to 4 per thousand that was initially found. And we were recommending a fair amount of follow-ups. 25% of women with whole breast ultrasound were needed to have a follow-up ultrasound or biopsy, which is not an insignificant number. And they also found that only 16% of those women who were actually eligible for the test did have it. So it was not as widely employed as a mammogram as it does currently have. So they also found that whether patients underwent screening breast ultrasound was really dependent on the referring physician. So some referring physicians were referring all of their patients that had dense breast tissue to have screening breast ultrasound. Other referrers were saying, oh, we're not really going to do that yet. So whether a patient did have the screening breast ultrasound was very dependent on who was referring them. We also found that only 40% of patients returned for a repeat annual screening breast ultrasound, where 80% returned for an annual mammogram. And so we were getting a lot more compliance with mammography as opposed to ultrasound. And again, the recall rate, so the number of times that we called the patient back and said, oh, I see something on the study, I need you to come back for additional imaging or maybe a biopsy, was two times as high for the mammogram, as high in ultrasound as it was for mammography. And the biopsy rate was 3 times higher in ultrasound than it was for mammography. So there are clearly problems in trying to implement screening breast ultrasound into practice. It requires a great deal of resources. We need to screen many, many women in order to find those additional 2 to 3 or 3 to 4 cancers per 1,000 women. We do have to pay for the machine. There's a cost involved, a dedicated workstation for the radiologist to use. There are definitely costs involved. We do have to have subspecialty trained technologists. So these are ultrasound technologists that really know, have a lot of experience with breast imaging, and they typically require training time. The appointments can be rather long. Here at our breast center, it takes about an hour to do a screening breast ultrasound with an ultrasound technologist. And there can be quite a bit of operator dependency, meaning that we really put a lot of value in our ultrasound tech to be able to find things and have a lot of experience to be able to know what they're looking at. So it can be rather difficult. So because of all those problems, in 2012, the FDA actually approved a new technology. And that new technology is called automated breast ultrasound. And so what that is the breast can actually be scanned automatically by a machine. And so what you're seeing in this image is what's called an automated breast ultrasound, or ABUS for short. And this is actually a machine that performs the ultrasound itself. And it sort of uncouples the acquiring of images from the interpretation. So the machine, rather than having an ultrasound technologist who looks around and only takes images at the parts of the breast that they find abnormal or the parts that they question, the machine takes thousands of images and documents absolutely everything within the breast. The radiologist then reviews all the imaging, not just the images which were saved by the technologist with the handheld screening breast ultrasound. And this is thought to reduce operator error. This is thought to increase reliability and a reproducible interpretation. So this is an exciting new technology. In order to do the automated breast ultrasound, we need to have a wide, high-frequency linear array transducer, which is similar in size to a mammographic compression paddle. You can see one in the image here with this woman who's having an automated breast ultrasound. It's a pretty big footprint. It's pretty big, about the same size as a compression paddle. It is curved to account for the natural curvature of the breast. It follows the normal contour of the breast. We do put replaceable membrane covers on the transducer with every new patient. So, obviously we clean the machine between each patient and also put new membrane covers on. We use water-based gels on the skin in order to ensure that we're getting really great contact between the transducer and the skin. So what you're seeing on the patient here are those water-based gels. which can prevent poor contact and allow ultrasound waves to sort of pass from the transducer into the breast without any air gaps, which can sometimes create artifacts. So the acquisition for the automated breast ultrasound actually starts after placing the probe over the breast. There's a mild compression, probably not as much compression as you normally have for a mammogram. The patient lies on their back in their supine position with their arm overhead, as you can see in this image here. We do have trained technologists to perform the exam, which requires a fair amount of training time so that they can learn the correct position the patient needs to be in, as well as adequate compression so that they know exactly how much compression to use so that we can reduce any artifacts or air gaps that can occur. So in order to ensure adequate coverage of the breast, because remember, we said with the automated breast ultrasound, we're taking absolutely every picture of every nook and cranny of this breast so that the radiologist can review everything. So there are a number of various volumes that's done. And you can see those pictures in the bottom here, these graphic depictions of the various places that the transducer is put on the breast in order to make sure that absolutely every part of the breast is imaged. Each one of these volumes takes about 60 seconds to do. The entire exam time is about 15 minutes. Not every study has every single one of these volumes done. Typically, it's about maybe 3 to 5 per breast. So on average, I would say the exam takes about 15 minutes to do. We try to make sure that these volumes overlap so that every area of the breast is imaged more than once, so that we can make sure that the breast is imaged all the way from the sternum all the way to the axilla or the armpit. So the transducer or the machine is acquiring many, many sections, over 300 sections, which is a fair amount of images. So after these images are acquired, the data is stored and it's sent to a dedicated workstation where we as radiologists sit and look at all of the images. And these are what the images look like. So the dedicated workstation, once it does acquire all the data, once the data is obtained by the patient, it's sent over to the workstation. And these are what the images look like. The images on the bottom here are the transverse images. So this is the skin, here's the chest wall, and this is all the tissue in between. The images are obtained in the transverse plane, just like this, and they're sort of reformatted or we create a 3D depiction of the breast, as you can see in the top part of this image here. The yellow dot pertains to where the nipple is. And so the radiologist can sort of view the breast in multiple different planes and look multiple times in each of one of these volumes to make sure that absolutely everything is looked at. It takes anywhere from 3 to 10 minutes to review these studies, although I can tell from personal experience that that can range quite a bit based on how familiar the radiologist is with automated breast ultrasound, and can actually take quite a bit more time than that. But it's a really wonderful technology that we have started to employ here at our breast center. There are some problems with automated screening breast ultrasound. We really can't look at the axilla. We can't look at the armpit. We can't assess for vascularity or how elastic the tissue is, how pliable or elastic it is. That's not information that we can really get from the automated images. But there's not a lot of data to support its use yet. It's still very, very new. And while these automated ultrasounds can increase sensitivity, and so the sensitivity that's lowered by having a dense breast, the automated breast ultrasound can therefore increase the sensitivity when it's added. We do know that we're also increasing the recall rate. So we're calling back more patients. The recall rate is thought to be a little bit, a little over 4% for mammography alone. And when you add ABUS to it, it tends to more than double that recall rate to about 10%. We also know that the specificity of automated screening breast ultrasound is fairly low. And that's thought to be because it's a new technology, and that is sort of expected anytime we employ any sort of new technology, and should tend to improve with increasing experience. And we probably will see that. But there are real advantages to ABUS. One of the drawbacks of mammography, one of the gripes that we get a lot, is that we're tending that sometimes they can be mammograms can be associated with overdiagnosis. So maybe sometimes we're finding DCIS or cancers that may not actually become an invasive cancer. They're sort of there may be an element of overtreatment that is used with mammography. And so ABUS actually doesn't really detect DCIS. What it's thought is that ABUS actually detects real invasive cancers. And so that's one of the positive attributes of ABUS as opposed to mammography. And another one of the attributes of ABUS, or automated breast ultrasound, is something called the retraction phenomenon. And so what that is when we look at the coronal, or the 3D image, as you can see here, right in the middle of my screen, what this is showing me is something called the retraction phenomenon, where you tend to see a stellate pattern around a cancer. You can see the white arrow is sort of pointing to that here. And you can see it's sort of a star shape, a dark star. And what this is sort of a desmoplastic reaction that can occur in normal tissue surrounding a breast cancer. And this is thought to be triggered by some chemical agents, chemotactic agents, that can result in stiffening of the surrounding tissue. We can see it very nicely on the coronal reformats that we get on automated breast ultrasound. It's thought to be highly discriminative for breast cancer. We very rarely see it in benign lesions. And it tends to be associated with very slow growing indolent breast cancers. We don't really see it very well in fast growing, really aggressive cancers. And so this is something very unique to automated breast ultrasound, and we don't see it with other modalities. And so this is something that we've been really excited about, being able to use automated breast ultrasound. And so of the additional cancers that are found by automated breast ultrasound, about over 93% are thought to be invasive and lymph node negative, which suggests that this technology is really being used to find clinically significant cancers, not the DCIS that mammography can sometimes find. Okay, so that concludes the slides that I have for today. I hope that my presentation was helpful. Today we did review the definition and implication of dense breast tissue on mammography. We discussed breast density notification laws, both in Vermont and across the country, and how they can impact our community. We described what screening breast ultrasounds were, and actually talked a little bit about automated breast ultrasound as well, and some of the advantages and disadvantages of that, and its role in being able to detect breast cancer. So I hope that was helpful. I'm happy to answer any questions that you may have. Thank you very much.